So something a little different, where we're going to get you to do some work as well, perhaps. And hopefully the change of pace will bring you. It's been quite a full-on day, actually. I'm beginning, don't know about you, I'm beginning to feel it. We referred earlier to this way that we find issues that sort of that appear to have crept up on us and become very big, but when you actually look back, we all knew they were there and we all knew they were coming. So we mentioned the growth of antimicrobial resistant organisms and healthcare-acquired infection, which crept up on us over about 5 or 6, maybe 8 or 10 years even. The workforce crisis, we did see that coming. If you go back and look, people were talking about it. We didn't seem to, though, get to the point where we felt we should actually do something in many ways. So we thought it'd be quite useful to just get you to do a bit of scanning to see, well, what are the other things that are hidden in plain sight that maybe they're slow burn issues. And this seems to be the characteristic of these things. They're slow burn rather than, we're very good at crises, but we seem to be quite poor at dealing with the slow burn. So we asked a number of you to nominate a few areas. So we're going to hear from some of those people, and then we'll see if we ask you if we've missed anything. Then we're going to ask you to see which do you think are the highest impact, highest likelihood ones. And at the end of that, we may be better prepared for the next crisis, or we always just go back to our dormant state until it gets really bad. So that's so Fiona's going to take us through, and we've got short contributions rather than longer talks now. So off we go.
Great. Yeah. So we asked people, we asked all you who were coming to nominate. We had a fantastically rich response, and we've tried to do some grouping of the themes, and we've come up with 3, and which all interlink with each other really, and I'm sure that there will be more that come up. So what we're going to do is we're going to have, some people have been volunteered, shall we say, to give a couple of minutes more context for each of these 3 themes. Then we're going to have a few moments to say, okay, so there's something blindingly obvious that we've clearly missed that ought to go onto this neglected burning issues list. Then we're going to have some table discussion. And then at the end, we're going to have an outbreak of democracy, and we're going to vote for the things that we think, if they happened, might have the most impact, and some assessment of how likely it is that these issues, which, as Nigel says, are currently hidden in plain sight, actually may become a real issue for us all. So the first issue, we've been talking about it a lot in-house at the Nuffield, about, are we a bit complacent about the place of the NHS as the national religion and its place in society and its unassailable legitimacy? Maybe we are. And what are some of the issues that you might group underneath that may actually pose us some problems in the future? So the first contributor I'm going to ask to get up and give us a couple of minutes of provocation is Greg Fell from Sheffield. I can't see you from here. There you are. Okay, you're going to come up here. You can do it from wherever you like, actually. I shall make room.
I'll do it
do it from here. Okay.
I was asked to speak with no slides, so I'm going to speak with no slides. 2 minutes, 3 minutes maybe. 2? 2, all right, boss says 2.
Time to sit down then. That's because you're not mic'd, Greg, that's why.
Technical support. So Greg Fell, I'm Director of Public Health in Sheffield. And I'll talk about the ethics and the opportunity cost of orphan drugs. I'll stray into other areas. Making decisions about whether or not to allow or not allow NHS funding for stuff isn't new. And the debate about expensive but and not cost effective is not new. Our decisions in this space carry enormous opportunity cost. And I think, as some people have said already, the drivers of cost growth in the NHS is not the ageing population, but overdiagnosis, new technology, and new cases of illness. So that underscores the importance of prevention. This isn't new. It's not that unpredictable either. And it's worth saying frontline clinicians make rationing decisions every day. NICE have done an amazing job over 2 decades, probably more. I criticise NICE from time to time, but I'd far rather be in a nice world with NICE than without it. NICE are constrained in many important ways. Firstly, most importantly in this space, they cannot consider the affordability, thus the opportunity cost of the things that are recommended in technology appraisal programs. They're bound to consider the cost effectiveness, but not how much it costs to implement. That matters for reasons I'll come on to. Secondly, commissioners or payers are rarely involved in NICE decisions. I've been there, I have been, but it's more the exception than the rule. Thirdly, generalist clinicians are not as involved as they should be in the NICE process. And all of those things matter and have allowed really, really expensive, sometimes really effective drugs into the system. That carries opportunity cost. Second point, NICE have been circumvented in a number of really important ways. Chris Whitty's already said the cost per person per year for cancer drugs has hiked exponentially over the past 20 years for no additional value. The Cancer Drugs Fund, last time I looked, was 300 million quid. I could run the country's parks for 300 million quid and probably buy more health than the Cancer Drugs Fund buys. The end-of-life premium, you can have a cost, you can approve a drug for £60,000 per QALY compared to £30,000 per QALY. There is no empirical evidence that there's a societal preference for an end-of-life premium. And again, that matters, and that's allowed expensive drugs into the system. Orphan drugs. So you'll have read about Orkambi, expensive drug for cystic fibrosis patients. CF's not terribly uncommon. Orkambi costs £100,000 per patient per year for their life. Eculizumab is the most expensive orphan drug I can think of, £250,000 per patient per year for life. Immunotherapies for lung cancer. The lung cancer doctors, don't know if any of you in the room are really excited about immunotherapies for lung cancer. Lung cancer is not uncommon. So these things matter. They get into the system. The orphan drug agenda is inflammatory. Right, okay, the orphan drug agenda is inflammatory. The skilled use of political and social media, this frames how policymakers think and act, and that matters. Here's the rub. The opportunity cost is vast, significantly vast. That's your social care budget. That's your CAMS budget that's being spent there. And there's little to no public discourse on the opportunity cost, and there's little to no public research on whether or not there's a societal preference for really expensive drugs or not. Be minded that that is your social care budget. That's your mental health budget being spent there.
Wow. Okay. Greg, thank you. Thank you. If you could, oh no. Okay. 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 Catherine. Sorry, I wasn't going to drag you up here, but you're here now, so.
Thank you.
Go, Catherine Lissett.
So I'm a diabetes doctor in Torbay in South Devon, and my question's about, following on from what Greg said, is about rationing and how we do it. So we know that we have to make difficult decisions. We know that we're told we have to fund IVF, we have to fund lithironine, we have to fund certain expensive drugs. The question comes, how do we make that decision? How do we engage the people in our communities in that decision? Are we open and honest that we need to ration? So my question is to have a debate about how we make those decisions. Do as an STP, we create a people's panel. Do we try to get true equity of people involved in that panel, as Claire was describing, involving carers, and then do we ask them to rank what therapies they want? How do we decide whether we fund a park, CAMS, medical therapies? Can we have that national or STP-wide decision about how we fund? Is that the right thing to do? Do we trust our populations to make that decision? And if we aren't asking them, does that mean that despite all this hype about being patient-centred or people-centred, we don't actually trust our populations to make that decision? So my request is for an open and honest rationing discussion with all our service users about what we pay for and how we spend the money.
Thank you very much indeed. Thank you. Hi. Okay. So, as I said in opening, the closely related overlap. So one aspect of the troubling discussions we've been having about the legitimacy of the NHS is the NHS coping with new challenges, also coping with challenges to its authority, if you like. And here is a related issue, questioning, challenging of the validity of expert opinion, whether it's anti-vax, the erosion of trust in experts. Is that a big threat for us? Should we be taking it seriously? Got two people who are going to talk on that topic. Stay there, aren't you? So Vanessa, could you take the microphone over there? And first, we're going to hear from Charlotte Williams.
As a reaction to the backlash against expertise, I'm not going to take the lectern. I'm going to talk from the floor. So we've heard today about the growth in subspecialisation, particularly within medicine, and in the pursuit of science, the increasing splitting and subcategorisation of diagnoses. And often for patients, they need to access that diagnosis in order to unlock care. So particularly in things like educational needs and other areas, that can give an ownership and an expectation of a response. But what's the downside of this for our patients? So through access to information that's been opened up through the internet and other fora, I can own that diagnosis and I can use that in positive ways to interact with my clinicians and plan my care. But are there risks with that? I see two possible risks. One, a tension with the tyranny of expertise. So Western culture says I should respect professionals, that they have a higher sort of moral status through their additional learning and knowledge. But is that some know-it-all coming to tell me about what to do in my life when I exist in my world with my belief system? The second risk I see is the proliferation of misinformation. So I can perceive that diagnosis and how that relates to me, or I can perceive what the symptoms that I seem to be experiencing in my world, and I can have my own interpretation of that, and I can see the interpretation that's given to me and the interpretation that I make as the same. And as a result, I can encourage others to do that. In a way, I'm not seeing the workings that exist behind that opinion from my specialist. So I think these lead to questions for us in terms of healthcare services as what's our role of the clinicians of the future and the role of engaging our population in a different dialogue around diagnosis and expertise.
Thank you very much. And now Claire Lamer.
So I'm a paediatrician, so I'm going to frame this as a paediatrician, but you can contextualize this to any part of medicine. So myself and my colleagues are increasingly seeing that when we interact with children, there are actually three groups in the room every time there's a consultation. There's the patient, there's their family, and there's the social media support group. And that leads to a number of different challenges. One of them, which I think is crucial, is where the expertise sits, whether it's with the clinicians or whether it's with the social media support group, and what that means for trust between the families and the clinicians. I'm clearly oversimplifying, it's more nuanced than that, but I'm trying to explain the kind of challenges that we face. And what that leads to is a really difficult situation for three different areas. One is the patients and their families themselves, they're very torn. Two is the staff, particularly nursing staff, who have to interact with families if they're inpatients, often with life-limiting conditions, on a daily basis and really struggle to manage those two differing areas of expertise. And three, and I think this is often a forgotten area, that what tends to happen in a situation like this is that the levels of intervention get driven up. And what that means is it's an ever-increasing level of intervention because the social media support group then pushes to the next level, potentially with the next patient that's involved. So our challenge as clinicians is how we balance all of those various different elements in a way that is true to our responsibility to the patient, but also to the families.
Thank you. Thank you very much indeed. So the third theme that we've identified is very, very broad indeed, as have the other two been. Looking at the way in which major events impact on our ability to run a health service and the way in which we respond as a service to trauma. And the context that some of the submissions came in, some submissions were talking about big public traumas like the Grenfell Tower disaster, and others much more locally about a caseload right in front of them and a tragedy right in front of them. But in both cases, how well equipped is the NHS to deal with those issues? So if it's all right, I'm going to ask, first of all, Fazana to speak. Would you like to speak from there or from here? You'll come up here. Okay. Thank you.
Can you hear me? Can you hear me all right? Yeah. Hi, I'm Fazana. I'm a GP in Newham in East London and also clinical director for one of our primary care networks. And I wanted to talk specifically about the trauma of knife crime. We heard a lot today about how much there's been progress about CVD, and that's had a positive but a knock-on effect of people living longer in dementia. But our children are dying. Just in my own practice, I run a list of 5,000 patients. I have lost 2 children just this year, victims of knife crime. We have a clinical cabinet that many of our trauma surgeons sit on locally, yet we're seeing an increase in knife crime. I think that trauma is not just one of the wider determinants of health that we talk about. The wider determinants of health are actually a major cause of our current health issues, and they're intimately entwined. I think as we can risk profile diabetes or heart disease, I believe we can actually risk profile the problems of knife crime, and I think we need to take a much more proactive attitude. I've just out of my head thought about risk factors such as housing, issues, homelessness, maternal health of our young people, as Greg's described the difficulty, CAMS now, school exclusion, bullying at school, county lines, which is rife in many cities and even in rural areas. And there are other risk factors such as our young children going into A&E with fractures that have been from self-inflicted and punching. So I think that we need to treat these traumas just as we would treat our physical illnesses such as diabetes and heart disease and cancer, because I think that's going to be one of the major health issues in the future.
Thank you. Thank you. And coming up to join us is Catherine Scott. Welcome. Does that work for you? Okay.
Hi, so I'm talking about trauma from a much broader perspective, and the idea that I submitted was more about the kind of the convergence of what I see as a big room, sorry, of 3 trends. So firstly, a negative trend in being that there is, however you want to measure it, an increasing number of crises that are leading to psychological trauma, and they can be man-made. So, talking about terrorist attacks such as Manchester Arena or Grenfell, and knife crime, as Fazana's just talked about, and also an increasing number of refugees and the trauma that's created from migration and from being from fleeing from either climate change or from war. Then there's also a growing awareness, particularly in the psychological community, about the impact of adverse childhood experiences. Now, this is an area where, we're talking about things like abuse and neglect, domestic violence, having a parent who has mental health issues or is substance misuse issues, and actually that some of the responses to that are happening in the other devolved nations are much further ahead than we are here in England. And then obviously natural disasters, flooding is all over our TV screens at the moment, and that can create trauma from leaving your home or from being separated from family. I think there's 2 positive trends that kind of come in at the same time. One is around the fact that our expectations around mental health and our expectations about what will be done for our mental health in these sorts of scenarios is changing, and we're expecting more. And coupled with that, what psychological professionals actually have to offer is growing, and the improvements in evidence-based interventions and what can be done in terms of screening, debriefing and specialist interventions around trauma. So as those 3 issues kind of come together, why is it important? Well, I think at every level of the system, we need to be thinking about trauma-informed practice. So that can be right from kind of government disaster planning. So how do we think about psychosocial trauma at that level? Thinking about our emergency service personnel. I read something yesterday around the fact that previously, police, long-term sick in the police force used to be mainly due to musculoskeletal problems, and now it's mainly due to mental health. So there's a real population out there that we need to be thinking about and how we're going to support them, people in recovery organisations facing the same issues, and then thinking about trauma at a community level and around individual level. So in response, I think as Fazana put so eloquently, we need to anticipate and predict and think about how we can prevent this. We need to respond to it, and we need to use trauma-informed practice in order to help our populations recover. Thank you.
Thank you. That's great. We've probably got enough to talk about already because there's such a rich diversity of issues. But I will just take a couple of minutes in case there are people sitting there thinking, yeah, but this issue really needs to be brought into the arena and onto the table discussions. But I'm going to be strictish. So, for example, if we take what Chris Whitty said, I wouldn't have accepted workforce because we have known about it for a long time, but the particular issue of paediatrics that he brought seemed quite new. So before you put your hands up, if you can think about, if you've got an issue that you think is burning, but it's pretty well known, then try and refine it or come up with something that isn't quite so obvious. I'll give you a couple of minutes to think about that, and we'll see if we get some additions to the list, and then we'll move into table discussion. Sorry.
Ruth Isden from Age UK. I won't quite add ageing to the list because although we seem to know about it, we also seem to have a great capacity to forget about it. But I think it's actually ageing in some of the unique contexts that we don't think of older people in. So we're increasingly aware that actually all sorts of people in circumstances which we don't think of older people, so within the LGBT community, in homeless shelters, living in severe poverty, in secure mental health units with learning disabilities, in prisons. I'm often told there aren't older people in these contexts, when actually increasingly we're seeing evidence that older people are aging in these contexts as we're aging across the piece. And actually what we're seeing increasingly is services don't know how to deal with this. So older people services don't know how to deal with people who are bringing that level of social complexity, and too often services that are used to dealing with people in those circumstances don't know what to do with older people who arrive. So I think we're missing a trick when we think of older people in that very stereotypical older, frailer, kind of mainstream way, which we're starting to get to grips with, but we're missing the fact that actually people are aging across the piece. People who've been in dysfunctional circumstances all of their lives are still in dysfunctional circumstances when they age.
Thank you very much.
Can I just add to that? Andrew Sutcliffe, the Chief Executive of the Nursing Midwifery Council. Actually, one of the things that we're missing from the ageing debate is people who are ageing without children. So if we go back to some of the things that Chris was saying earlier, there is an expectation that we will rely upon informal carers, family members. 1 in 5 people over the age of 50 is ageing without children. I'm not going to have somebody looking after me and doing the things that I'm doing for my mum and dad. And actually, there's an awful lot of us that are going to be in that situation. I really don't think we're thinking about that one.
Okay, thank you. Over here. Thank you. Is that Richard? Yeah. And then you at the back. And then I think that's probably going to be enough. Yeah, Richard.
Hi, Richard Beaumont, Nuffield Trust. The one that I think is going to sneak up on us is that we are successful. And every time we're successful, we create whole new populations of needs that we didn't think about when we were trying to be successful. I'm showing my age now, but when I was at medical school, there wasn't a thing called cancer survivorship. And now we have whole populations of patients with cancer survivorship. There are increasing number of diseases that we are not able to actually cure, but we can put into remission with monoclonal antibodies and advanced medications. But those patients still have needs. They just have very different kinds of needs for which our systems are not. So I fear that we're going to create this whole tail of different needs that we haven't thought about because we've been successful. And we don't think about what are we going to do with success. We think about, gosh, how do we get to be successful?
Okay, thank you. And gentleman at the back, and then we'll summarise and we'll go on to the tables.
Rob Yeldon from the Charter Society of Physiotherapy. I'm probably a bit too close to a speaker. My bid is for rehabilitation to be considered. At the moment, rehabilitation is hidden in penny packets across a whole range of individual patient pathways, so it's not really considered as a need in its own right. Matt was talking earlier about adding the quality of life to years, not just number of years. If we think about the impact on social care, on secondary prevention, rehab is going to be increasingly important. Yet we know currently most patients who would benefit from rehab are not even offered rehab across a whole range of conditions. So I think in the next few years we're going to see greater demands for a parity of rehabilitation being treated as an absolute priority in the same way as we would treat surgery, medicine, nursing and all the other elements of the NHS.
Great, thank you very much indeed. So we'll move into table discussion. So in addition to the 3 issues that we have on the slides, we're going to capture the conversation that we've just had. So 2 different aspects, 2 different challenges posed by ageing, the differing needs of less advantaged groups and the needs of people without informal carers, the consequences of success and what that may mean for new treatments and new developments that will be required to support survivors or people who live to have another disease altogether, as Chris Whitty said earlier with dementia. And then I guess you're arguing that if we don't make rehabilitation something rather more central and more of a priority, then we're missing a major opportunity to improve quality of life. Is that a fair summary? Good. Okay, so we're going to, if you'd like to stay at your tables, some of our trustees, senior associates and staff kindly volunteered to be facilitators of the table discussions. Would you, if you remember doing this, would you kindly put your hands up now so I can see where you are? Okay. So if there's any with 2, I think if you're all on different tables, that's great. If you don't have somebody who's kindly put their hand up, you're going to have to shift for yourselves. So if one of you could kindly take on the role of taking a few notes and just keeping the discussion on track. Okay, over to you.
Yeah, so what are you doing?
Yeah.
What we would like you to do is to think about what will happen if you don't do this, where will the impact be felt, and do you have any solutions or thoughts about what we should be doing, okay? Just 10 minutes, we'll just do 10 minutes on that, okay, and see how you get on. Yeah. We're not going to do a huge feedback, don't worry. We will collect your thoughts though, but maybe we'll just have a, oh, that table looks like it's going to have to give some feedback. So, okay, have I got you back? Have you left us some sort of tangible record of your conversations? No, you've failed. You've totally failed. Let's just get a few headline thoughts back. So there is a roving mic. Who'd like to share something that you thought about? Or Nick, there's Nick. Thank you, Nick, and there's Pete Smith. So.
Okay, we actually managed to merge the first 2 and focus
they do sort of,
on legitimacy, on the grounds that number 2 was very much about this increasing potential clash between the traditional expert of the doctor, the nurse or whoever, compared with the patient who is becoming much more expert, backed up with social media and anti-vax people and God knows what. And in fact, number 1, the legitimacy of the is in some ways that's at the individual patient level. The legitimacy of the NHS is almost at the macro level of a public view against that of the sort of people in this room where we'd all feel that probably vaccination was a good thing. And to be shorten it enormously, our solution was that we'd like to see lots of experimentation with deliberative democracy at all sorts of different levels.
Okay. Great, thank you. Yeah, they do sort of, the first one was more macro. My shorthand for it was, when Matt Hancock was saying, you know, the NHS is a greatly loved institution and we're right behind it, I thought, well, that's what we used to say about the BBC. So, first they came for the BBC and I didn't say anything. So that was, and then the second was more about this point about everyone's an expert. If you've ever taken a taxi, for example, Pete. We'll come here and then we'll go to Pete. Yeah, yes.
Hello. Well, at our table, we the first thing we did is to look at which of the issues we thought was the most important and pressing, and it was entirely unanimous, which was trauma. But we also felt we ought to be fair to the other issues, so we discussed them as well. And in particular, we talked about prioritisation. and discussed the Oregon experiment in the 1980s when that was put to the members of the public as to what should be prioritised, and it didn't work because the members of the public had a very narrow picture of what was relevant. So we did agree that in relation to prioritisation, it should be nationally planned, regionally managed, and then locally owned. But in terms of trauma, we had a very good discussion, but I think the most important thing that we discussed was that we had to involve the relevant groups into finding the solution, and that it had to be a bottom-up approach and not a top-down approach.
Good, thank you. Peter.
Thanks very much. We had a very enlightening discussion, and we focused on how the health system should be designed in order to accommodate these left field things. And so we talked very much about trying to introduce flexibility and agility into the health system. And that can play across a wide range of parts of the health system, but just to take some examples, it implies a workforce that is trained and accepts the need to be agile and flexible. Governance should be flexible and not rigid in the accountability lines it has, and so on. Cross-sectoral collaboration ought to be encouraged by the system and not completely stymied by it. And systems of finance oughtn't to be getting in the way. And of course, underlying all of this, you need information systems that are actually helpful and timely and so on. So in doing those sorts of things, we would reckon that you could design a resilient health system that would actually be able to respond to these things in a sensible and efficient way. So that was the way our discussion went on this.
Great, thank you. And picking up actually the point that Chris Whitty was making about generalism, about this point about generalism and the ability to not just work in your own little silo, seems to work at different levels of the, it's come up a number of times in the conversation, and as a way of making the system perhaps more robust and agile. That does seem like a good thought. Anyone else like to share something? Luella, yeah.
So we had a really interesting discussion along similar lines about this issue around social media, and actually one of the things that we rapidly came to with a couple of things. So one is the problem of cognitive dissonance, which is both healthcare professionals and patients and groups can want multiple things all at the same time and hold completely contradictory sets of views which you completely believe are true all at the same time. And this actually means that having a rational discussion in any direction is problematic. And then we also moved on to the fact that experience of, I think a number of people at the table were very struck by the fact that of the notion of Chris Whitty's window of death is narrowing, that most people now die in a very narrow 20-year period, which means fewer and fewer people are experiencing death, and how anxiety about death drives medicalisation at both ends of the spectrum. So increasing expectations about what's going to be done when you are in the death window and the cost of that, but also anxiety in the younger groups that was being brought up about medicalisation of conditions that previously actually didn't exist, and how the solution to this is still actually yet more healthcare, and how do you manage that in this incredibly how do you manage all of that? And is this just societal expectation driven by fear and anxiety, as you've previously mentioned? And how do doctors engage and set an agenda for that, given how complex these discussions are and that doctors frequently
So that social media thing, it actually conceals a much deeper vein of big issues that are going on that we haven't even, if you just scratch the social media surface, you haven't really got into what's actually driving some of that behaviour. Excellent, good. Yeah, we'll come to Ian, yeah, it's Ian here, yeah, good.
Hi, we had a really interesting conversation to try and almost have a taxonomy of how some of these different things came together, and we crudely split them into the big question of what are the kind of things that are going to mean the NHS is not sustainable, and we put them mainly in two buckets. So within the context of unexpected demand shocks and unexpected supply arrangements. And on the demand side, we talked a little bit about, and this goes to your social media point, our failure to understand the changing nature of how we are living and what that means in the widest sense. on some of the particular risk factors, a failure to really understand the consequences of obesity and what we're going to do on obesity, which we haven't talked a lot about.
No.
The potential medium to long-term health consequences of the climate emergency, as well as the questions around the changing nature of asymmetries of information, which Claire, you were so articulate about. And then on the supply side, the things that you may not have factored in properly to almost our supply-demand model, the extent to which we have a proper grip, not just through defensive medicine, but changing nature of clinician risk tolerance. So the extent to which people are just now ordering a shed load more tests, for example, and that's actually one of the reasons why A&E is getting clogged up, and nobody talks about that. They just say, oh, there's more patients. And Peter's done great work that explains that. Or things like, picking up on the carer's point, what's the ratio between the total quantum of informal care in society versus formal care, and the extent to which, if that significantly shifts in the way we're not looking out for, it will have profound adverse consequences for us.
Great, thank you. So Nav, yeah, we'll take one more. You've all done a really good job of kind of regrouping what we gave you, which is going to make the next exercise rather more difficult, but never mind. We'll do it anyway. It's all fun. It's just fun for this next bit. Nav, yeah.
I just wanted to give a different nuance around the paternalism versus sort of self-actualization that's going on in society at the moment. So it's kind of linked to social media point, but different. And it's kind of what I call high street healthcare, that people are now have the ability to access a whole raft of diagnostic tests in a variety of different settings which are outside of healthcare, and that's particularly noticeable outside of England and the UK. And I wonder what over the next decade, if you can scan your heart and you can get your ECG done, you can get point-of-care tests done in a variety of settings, what the impact of that could be around.
Because presumably at some point in transaction, there will be a bit that says you now need to go and see your GP.
Or possibly, or it might just be that that's the flip side of paternalism, isn't it? Because normally you'd go and see a physician to get access to those sorts of things, whereas people can now get access to all of those things outside of seeing a physician, but then what do they do with all that information?
Yeah, good. Okay, lots of good things there. I'm just looking at the back. Do you want to run that vote thing now? Because they've moved all the categories around. Let's do it anyway. Have you got your Sli.do things ready? We've got the Sli.do question for you that we'll get you to just do. This is more temperature testing than science, right? So you've got a choice to vote. Which issue of these, and I know you've regrouped them, and we haven't got time to regroup them back again, but into your, so we'll make you, someone's voted. That's democracy in action. Good. Which will have the greatest impact? We didn't put climate on here because it sort of fell under trauma, but it is sort of, yeah. I like the demand supply shock thing. That is good. Increased rationing. Yes, okay. Never quite sure why these go down. Is it because they're being rescaled, or is it people are changing their mind, or is there Russian interference being? It's the Russians. It's the Russians. I'm sure it's the Russians. Yeah. That's, good. Yes. Yeah. You can change your mind. Yeah. You can, and if you've got more than one phone, of course, you can vote more than once. So. If you've got a laptop and two phones, you get 3 votes. It's like Northern Ireland, but with technology. Okay, looks like we've got we've got a bit of a winner here. But I think, as Nick said, 1 and 2 really sort of are quite closely related. Yeah, trauma's coming up on the inside. Jolly good. Okay. Some good thinking there, actually. Some of that group work did actually take our thinking on. Can we make sure that we collect, just so we do, I think there's a blog in there somewhere probably that we ought to try and collect things together.